So I think, as everybody knows, that, with the advent of very potent, tolerable antiretroviral therapy, the fastest growing cohort of people with HIV are those over the age of 50. And this is also the group that is experiencing higher rates of comorbidities that are age-related, but also geriatric syndromes such as frailty, neurocognitive impairment, and mental health issues. And with the need to prevent and manage the comorbidities, we're also seeing polypharmacy in this group of patients. There is debate about whether these comorbidities and frailty syndromes are occurring at a younger age or they're occurring at the usual age that we would expect to see them, but at greater rates than the general population. So I think if we look back to prior to potent antiretroviral therapy, and there used to be rates of HIV-associated dementia of about 15%. We do not see HIV-associated dementia. These days it's extremely rare. But there have been many studies done that show that there are quite high rates of asymptomatic neurocognitive impairment in our population of people with HIV. And these people can actually progress to symptomatic neurocognitive impairment. We also need to remember that our patients who are aging are at risk of vascular dementia and Alzheimer's disease, so it's important to screen for neurocognitive impairment and then go on to more formal testing. Frailty is different. Frailty isn't just HIV and comorbidities. You can have two patients with the same number of comorbidities or the same comorbidities, and one can be quite robust and one can be very frail. It's a different geriatric syndrome that's worth screening for, because you can screen and determine when someone is pre-frail and maybe intervene with some very simple interventions and either prevent progression or return that individual to a more robust state, improve their quality of life. So what are our recommendations as far as polypharmacy, frailty and cognitive function screening go? So we're recommending that we assess mobility and frailty in all individuals with HIV who are over the age of 50, using an assessment tool that has been used in people with HIV previously. The frequency of assessment is guided by that initial assessment. So it should be more frequent in people that are frail or pre-frail, but those that are robust, you don't need to do it again for another 5 or so years. In those that are frail or pre-frail, it's worth considering a complete geriatric assessment and institute exercise and physical therapy, nutrition advice, mental health assessment, and also pay attention to the polypharmacy. We also recommend the routine assessment of cognitive function every other year using a validated instrument. And we recommend this in people that are a little bit older than those that we recommend the frailty assessments. We're recommending it in those that are older than 60 years. So how do we actually assess for frailty? Now, there are a number of different tools. This is the frailty phenotype, and it has a number of domains. You look for unintentional weight loss, weakness, exhaustion, slow gait, physical activity, and this is all scored based on gender and age norms as robust, pre-frail and frail. Now, the weakness is actually assessed using a dynamometer, which not many clinics have. So this is a difficult screening tool to use. So can we go to the first poll question for the audience and ask, how frequently are you performing frailty assessments in your practice? Not at all, only when you suspect someone's frail, or at regular intervals in older people with HIV. And can we see some results yet? Okay, so the majority of people aren't doing any frailty assessments in clinical practice. Yes, and minimal people are doing it at regular intervals. So can I move to the panel? How often are you doing frailty assessments? What tool do you use, and how often are you screening? Raj?
You know, this is an area I wish I did better at. Let me put it that way. I think, you know, the frailty assessments that what we've been trying to do is integrate our geriatricians into our clinics. I think as primary providers, things like gait speed and being able to get out of a chair, there are some things that I do think are useful. But it's not something that in our ID clinic we've done as well as we could. I think we're using these guidelines to try to, you know, get us, like I think the audience, to get us to a more systematic approach. I take my lead actually from, you know, some of the people on this call, like Melanie, Thompson, and others, and I'd love to see how they have integrated it into their clinics. I don't think we've done it as well as we could.
What about you, Melanie?
Oh, you're muted.
You're on mute.
Second time today, I get the award. So I'm not sure that I do it as well as I could either, but I do try to be aware, first of all, that these frailty phenotypes can happen at an earlier age. And so, you know, we don't like to think of people who are 50 as being older. I mean, I certainly don't like to think that way, being fairly past 50 myself. But I do think that these things can show up earlier. So I try to make this sort of an annual assessment as appropriate at a physical exam time for patients who were able to get in for an annual exam. It actually doesn't take as long as you would think to do some of the basic assessments. So, you know, certainly the Fried's frailty phenotype, which is kind of a tongue twister, is fairly easy. It's about weight loss, which you can calculate. It's about exhaustion, which is a question, you know, a couple of questions for the patient. Energy expenditure, how active are they? And then looking at their gait, how quickly do they walk? Now, this is the one that has grip strength, and that's where, you know, the equipment comes in, and I have to say, I don't do that. We don't have one in my clinic, but I do try to assess some of the other things that would be important contributors to frailty. For example, being sure that we're not talking about depression, because depression is very common for people in general, but also people with HIV, and especially as they age. And we know that depression can take many forms. And so I think being sure that we're not dealing with depression, which should be treated differently, or with substance use. And another thing to me that's important is to look at social isolation, because we see that so much in our older patients, but also it's more common in people with HIV than people without HIV as they age. So an assessment of their social networks. And, you know, I find this is more and more important in the time of COVID because I think we all feel a little isolated sometimes. And for some people, it's not so much of a problem, but others are really suffering. So I kind of lump that into the frailty assessment.
Yeah, I mean, I think what Melanie says, I think is really important. I don't do the tensionometer or whatever, but you know, frailty, you know, you can look at physical shrinking, unintentional weight loss. You can look at the ability of the individual to walk. How long does it take to walk 15 feet? And, you know, you can look at their level of physical activity. You can look at their mental health and a couple of things, and it will get you to understand that this person is having problems with frailty and how do you need to address them.
Right. So we were involved with a couple of studies, and that got my attention. This is about 3 or 4 years ago, where we used grip strength and we used a 20-meter, no, wasn't that long, 10-meter walk, and it was remarkable. We looked at people who were even younger, and some of it may have been deconditioning, but a lot of the folks didn't do well at all. So that sort of got at least me personally thinking more about this, and I'm very happy that the current guidelines are taking this on, because even though people aren't doing this regularly yet, we're in that pre-contemplative phase, right, where we're about to do it. And I think if we all commit to this, it will make a difference. The geriatric literature, or let's say the geriatricians I've talked to, don't even necessarily do a lot of these formal tests just routinely, but I think we can lead the way, the HIV providers in this, because I think it does make a lot of sense. And as you said, Melanie, it doesn't take that much time. You can do sit, stand 10 times in a chair when people are getting their vital signs. You can have them do a grip strength there, record it, and then as they're walking to the exam room, you can time the 10-meter walk or something like that. And that doesn't take a lot of time. What we often see as an indicator of frailty is falls. And I think that's something we should be asking about routine. It's a simple question. Have you had an unanticipated fall? And that's a really major event as far as annual 1-year mortality even. Yeah. So those are the kinds of things we can do.
And in fact, there are a number of different tools we can use. Sorry, Melanie.
I was just going to say, I think the fall issue is a really good point, because people often have an excuse for why they fell. But if you take it a little bit further, sometimes you will find that they actually are having trouble with balance. And I didn't mention balance, but those are other really easy tests you can do just to have someone stand on one foot, you know, walk a tandem gait, things like that. But even when people think that their fall was totally excusable, there may be something else going on.
And I was going to say there are a number of different frailty assessment tools, some of which include all of the things you've talked about, and in particular the Edmonton Frail Scale actually includes the social isolation that Melanie was talking about, the falls, the balance, and also some neurocognitive issues as well. So look at the different tools and see which is best for you. There are barriers to doing this in practice because we have to do so many things when we do annual assessments in our patients, the cardiovascular risk assessment, the bones, everything else, and fitting this in can be quite tricky. Okay. Go on.
Before we go on, one other thing I'd like to add is that what we did in this iteration of the guidelines is that in the supplemental materials we include these tools that people can reference. So go online when you see the document, then you can click on supplementary material.
No, and Jenny, this is Paul.
Paul, sorry.
I just want to be kind of revelatory as well as the other guys here. We're not doing a good job of this, but I think that this could be actually one of the very important things of this guideline. And in this area, I think we all know it's an important issue in our patients. And I'm glad that we're giving people some of the tools that are needed to begin to incorporate. So thank you.
And just in the Q&A, there's a question about measuring quality of life. Just like Mike, we did a study of the prevalence of frailty in our clinic. It was a medical student project, and quality of life was part of that project. And people who are pre-frail and frail have significantly lower quality of life. We use the POSQUAL scale, which is an Australian scale that can be done online. And in fact, we're now introducing that into a pre-appointment completion so that we are aware of the quality of life issues for that individual prior to their appointment. The other thing I was going to mention was there's a move with the Frailty Index. If I can share my screen again. The Frailty Index is now being adapted to an electronic frailty index where you can use what is already on your electronic medical record to give you a sense of the frailty index in that individual. The frailty index to me doesn't include the physical frailty components, which I think are really important. We might move on to the neurocognitive screening in your practice poll question. Can we put this poll question to the audience? So how frequently are you performing neurocognitive screening? Not at all, only when you suspect that there is an issue or at regular intervals. Okay. Mostly when you suspect there's neurocognitive impairment rather than at regular intervals. I suspect that this is like most of us, that just as with screening for frailty, we're screening for neurocognitive impairment only when we see that it's necessary. I'm having trouble, yeah. So there again, we didn't actually provide any advice on what tool to use for screening. And there are a number of tools that have been used in people with HIV, the International HIV Dementia Scale, the HIV Dementia Scale, mini mental state exam, the Montreal Cognitive Assessment, and the European AIDS Society 3 neurocognitive impairment screening questions. Can I ask the panel, which scale do you use, if you use a scale, and how often are you screening? And also, how accurate do you find these screening tools, given that the majority of our patients are going to have asymptomatic neurocognitive impairment?
Maybe I'll comment here that we have been using the mini mental state exam. We have a neuro ID clinic, and so routinely they're administering this exam. One point that I alluded to before, and maybe worth just bringing out for a moment, is nadir CD4 count is a very strong predictor of a lot of these frailty and neurocognitive phenotypes. And so our patients that we've been caring for decades now are at the highest risk for that. And so we must be broad in our screening, but I think it's particularly important in people who have been living with HIV for decades and who had a low CD4 count to begin with.
There are some neurocog screening tests that you can incorporate into your EMR, or do some pre-screening as patients are sitting in a waiting room or in an exam room. One of which, Paul, you may know about this. It was developed at UCSF, and it's kind of more widely available, at least for research purposes. We're going to be implementing this into CNIC. There's a bunch of commercial ones. I don't know how to judge them. They're a little bit pricey. There's one out of Australia, Jenny, that I'm aware of, but we didn't purchase it. But I think people are kind of getting into this. And again, the geriatric practices don't do routine screening, at least that I'm aware of, not as a practice. So here's where HIV, I think, is going to lead the way. I think they're subacute or subclinical, neurocognitive impairment, I think we're going to discover a fair amount of. And my final point is that when we think about sort of dementia of some sort, we typically think of just, the older group of patients over the age of 85 even, but here in our younger patients with HIV, I'm just saying younger 55, 60, it's a little different because it's more the executive functioning. It gets a little bit out of whack. So it's more than just a memory problem. It's a processing problem. And those are the differences that some of these neurocog tests will pick up.
I guess Mike and Jenny, to be maybe a little contrarian, as we were saying earlier when we were talking about CD4 measurements, we don't have a drug for CD4, so why do we measure it? I've been a little bit of a skeptic of the asymptomatic cognitive impairment because I don't have any treatment for it, and I'm not sure how much good it does to tell a person that that he or she is measuring as somewhat cognitively impaired. I don't know. Can you react to that, Jenny?
Well, that's where I was getting at the accuracy of the screening tools, because if somebody is actually scoring as impaired on the tools, they're actually not asymptomatic, they're symptomatic.
Okay, but I mean, I saw a patient that we published in JADES a while ago that did a screening, I think it was in the UK, and 50% of people scored as impaired. And that, to me, what does that mean?
So man, woman, television, remember that?
Yeah,
anyway,
right.
So yeah, you can remember that. But the things, unfortunately, you're right. But there are data that show that engagement in training and physical training, as well as some routine exercise programs, not only improves frailty, but does improve neurocognitive to some degree. So that's something we could suggest until we get drugs or something that we can do to help. The other thing is that there may be a safety issue in terms of if somebody's living alone. Melanie, you mentioned the intervention, the isolation, but if somebody's living at home and they're neurocognitively impaired, there's risk of all kinds of things, from fire to other, like leave something on the stove. And the other problem is driving. And because driving is a complex set of functions. And if we stumble onto this in the screen, then you don't just stop there. You go ahead and get a formal neurocognitive assessment, which is a much engaged 2-hour thing. And then you talk to psychologists. But the purpose of the screening is as much for safety as it is for therapy.
Melanie?
I would agree with that, and I think they're also, sorry, Jenny.
Go on, I was wondering, what are your thoughts?
Are issues about polypharmacy, which we haven't really talked about very much. Sometimes when I do a screen and find that someone didn't score as well as they might have, that person actually has some awareness of that issue, and you can talk with them about it. But I also think it also should be part of our screening of polypharmacy, because many patients, as they get older, are taking so many different drugs. Sometimes the drugs can cause impairment. Sometimes we can find a reason, something we could fix. Or sometimes we need to look at the medication list and just review with the patients whether they're taking the drugs that they are prescribed or whether they're taking them correctly. So I think that is an intervention that's easy to do, but it actually sometimes gives you a hint as to why someone is scoring badly in terms of neurocognitive or even frailty. So the idea is we don't really have a treatment. I agree with that. But I think we can do some things to help protect people and actually sometimes even reverse some of the symptoms that people are displaying.
Yeah, and in that regard, the polypharmacy issue we briefly talked about in the context of boosters, but this drug-drug interaction issue that also arises is critical, because as people get older and get meds for other conditions, if it's interacting with their HIV meds, then people obviously can get into quite serious trouble. And when we talked about cobicistat-containing regimens and ritonavir-containing regimens with the over-the-counter drugs like fluticasone, et cetera. These are real problems.
And I was going to say,
they go to so many different consultants. They have all these different people that they may be seeing for different things, and sometimes even the patients don't know what they're taking. So, it becomes, I said polypharmacy assessment was easy. It's not always so easy because sometimes people really don't know what they're taking.
And I would agree with that. We actually have an HIV specialist pharmacist that actually looks at all of the medication that a patient is taking. And I recently had one of my patients who sees multiple doctors in multiple hospitals, as well as his general practitioner, who's your primary care provider equivalent. And not one of us had an accurate list of what medications this patient was taking. And there were all sorts of drug-drug interactions that were going on. And this patient is frail. So it's a very important issue. And if you can get a pharmacist to do a review of all the medications, I would recommend that highly. The other thing I was going to say was we often use some of these screening tools to go on to more formal assessments, the more formal neuropsychology examination, imaging of the brain, and perhaps even CSF analysis to make sure that we don't have viral escape in the CSF, which you can do something about. You can change your antiretrovirals. But you can also look at other factors that might be contributing. For example, alcohol. Alcohol use will certainly have an impact on neurocognitive function. And, we can change that with the patient. And I think the whole idea of these assessments is really to optimize the health of our patients and to improve their quality of life with very simple interventions. Do you guys have multidisciplinary clinics that an individual can be seen by a geriatrician, by a pharmacist, physiotherapist, a nutritionist, all in one sitting? Is that something that you have or aspire to, like me? I'm trying to set that up at the moment because we don't have the geriatric assessment clinic that I would like to have.
We have a very multidisciplinary clinic at the VA here in San Francisco. We don't have a geriatrician really embedded in the clinic, but we have easy access to geriatrics consults because it's such a big problem in that patient population. But we have HIV pharmacist, HIV psychologist. It's really quite impressive.
That's great. Very lucky.
So I would say my answer would be no. But here's a really great opportunity for telehealth, telemedicine, if we had a system that we could tap into where those resources were available. They're just not available in many places. They're not available in private practices. They're not available in rural areas where there may not even be an HIV provider. They're just not available in many places, but here would be a really terrific way to put together a telemedicine geriatric clinic that would provide many of these things, which really could be done by telehealth in many regards.
Yeah.
Jenny, you could put that together for us in Australia and we can use yours.
And come visit. Yes. So are there any other barriers, do you think, to doing these assessments?
That's too much COVID.
That's right. Australia does not want us, not Americans.
Not now.
You have to go into quarantine for 2 weeks if you come. What are the other barriers to doing these assessments, if any, do you see? I think Melanie has mentioned quite a few for individuals who are in rural areas, regional areas, not close to high caseload, clinics, public clinics.
Right.
And also the time for the provider to actually do all of this, I think, is an issue.
So I think Melanie mentioned the polypharmacy, which is readily fixable, and I think there are drugs that cause some degree of impairment. A question that we have from Michael Silverman here is, what about when you find somebody who's got what appears to be HAND, the HIV-associated neurocognitive disease, do we get a CSF to look for viral load that it might be up while this plasma viral load is suppressed? And if we see that, do we focus on more drugs that penetrate the CSF better, or what's the current thinking on that?
Personally, I think it's debatable. Our practice in Melbourne is that we do a CSF, we do look for CSF viral escape, and we do, it is recommended by our HIV clinician who is more experienced with neurocognitive issues. She does recommend switching antiretroviral therapy to anything with the best penetration effectiveness score. Now, I realise all of that is quite controversial.
That's frequently AZT.
We don't use AZT.
I actually remember this discussion on this very panel in about 1996 or 97 about whether we should put everybody, or maybe it was 98 when we had some other drugs, whether we should put everybody on AZT because of the CNS penetration. Interesting.
Yeah. So do any of you do lumbar punctures, CSF analysis, switch antiretroviral therapy in that scenario?
No.
In people who've had marked deterioration, we have been doing that. It's very uncommon, but we've done it maybe once or twice a year, 3 times a year. This will come up where someone has really a very unexplained deterioration. You can't blame it on polypharmacy. You can't blame it on drug interactions, alcohol. And when we do find it, which is uncommon, then we do modify it just because we don't. Once you find it, it seems hard not to make an adjustment, although we don't use AZT.
Yeah. Yeah. So nothing different with anyone else. Okay. Well, I'm not sure if there are any questions. There's no open questions. It is 8 o'clock. Well, no, it's not 8 o'clock your time. It's 8 o'clock my time.
I was going to say I might having neurocognitive impairment.
Yeah, it's top of the hour, and I think we're ending about a minute early, but I think that's okay. Thank you, Jenny. Great job. Jenny. And thanks for coming on so early in the morning. It would have been earlier, except anyway.
It's Friday. It's Friday in Melbourne, right?
Friday. Yeah. And you're out of lockdown now, is that right? You're
out of lockdown. I can have a haircut.
we're envious of your case. Tell everybody the caseload in Australia over the last month. How many new cases a day?
So on Monday and Tuesday, we had 0 new cases on both of those days. We've had 2 on Wednesday and Thursday.
So sounds like you're rounding the corner.
Yeah, we had.
Yeah, but
you stay there.
We had 2 cases in the last second. So we're right with you.
In your neighborhood.